graduated in Singapore and working as head and senior consultant Department of Respiratory Medicine and Clinical Care Medicine in Singapore General Hospital and associated with the Chin Health. He did his MBBS 1990 and did his postgraduate MRCP UK 1995. He had a lot of publications, more than 50 publications. He achieved the award, Ministry of Health Award 1990 and Young Investigator Award 2000 and Singapore Fellowship in Liver Transplantation in 2004. So he is our invited guest to speak on updates of asthma guideline. May I request Dr. Lu Chen Mei to deliver his speech, please.
Thank you. Good afternoon, Chairman, colleagues, and ladies and gentlemen. I want to thank the Asthma Association for giving me the opportunity to participate in the excellent program today and to be able to speak to you on asthma. My topic today is update on asthma guidelines. However, I'm not going to go into a lot of details as the previous speakers have already spoken a lot and given a lot of details on the asthma guidelines, but maybe I'm just going to speak on the overall change in the approach to the asthma management that has sort of evolved over the last maybe 5 years or so. So there are a lot of guidelines available. Bangladesh itself has national guidelines. The American guidelines was mentioned. The GINA guidelines from World Health Organization was mentioned, but are they really used? So as you can see from the slide here, not really. I try to draw references from the Asia Pacific mainly because we really do live in the Asia Pacific. We want to see how we are doing and what's being done in this region. So as you can see, there are many publications to show that the utilization of guidelines, be it national guidelines, international guidelines, is actually very low. Probably in the region of between 20 to 40% overall over the last, and these are relatively new publications. So, but do they really work at all? Again, there are a lot of publications from before more in the European as well as the American publications, but more recently some in the Asian publications have shown that they are pretty useful. They actually improve the care of asthma in general. And if I may sort of draw from quote from the GINA guidelines, the latest update was sometime last year. And if you notice, the goals and implementation strategies actually varies between country to country. So the whole idea is not to adopt any guidelines from any country and try to implement in your country or my country. And I think the key here is to be able to adopt these or adapt these guidelines to your local population and to use it to try to implement it to fit your local population so that you can actually meet the needs of the people in your country. You cannot just bring in some international guideline and hope to implement it, and you will probably fail. So, has it been done before? Of course, it's been done before. This publication came from Thailand, in this district in Thailand, where they adopted the GINA guidelines and they modified the guidelines a little bit and they implemented. And as you can see, they have very good results from that. It shows that it can be done. And so there are a wealth of guidelines from all over the world, and which individual national societies have formed and to implement in their own country. And it's very important to realize over the last 5 to 10 years, asthma has sort of changed somewhat, and we are still changing as we learn more and more about the disease. So number one is the asthma phenotype. As the second speaker alluded, asthma seems to be it's not really one disease. Patients have different symptoms, they have different presentation. Some have raised IgE, some do not. Some have raised eosinophils, some do not. And some present with cough, some present with more bronchospasm. And the response to treatment is also different, as many of you will realize by now after having treated many asthma patients. So now there's this new concept of asthma phenotype. It looks like maybe asthma is not a homogeneous disease. Maybe there are many different sort of subgroup of asthmatics. And I think the key here in future research is to try to identify subgroups or different subgroups so as to be able to help develop diagnosis, how to diagnose them better, and as well as to develop targeted treatment for this group of patients. And it's number one up here because it's still research in progress. There's still a lot of work to be done, but it's something to watch for in the next probably 5 years. Secondly, something quite important is this thing called empowering patients. I think asthma has slowly, I wouldn't say moved away, but certainly we have moved from a very doctor-centric kind of management towards a more patient-centric management. Again, as the previous speakers have alluded to, there's very low, a lot of patients, you can say whatever you want to them, you can give whatever medication you want to them. A lot of them have their own beliefs, they may not want to do it, they have certain concerns they have. And if you don't address all this, if you don't partner the patients, you will not be very successful in your asthma management. And lastly, I will touch a little bit on this thing of asthma control versus severity. So I just want to bring to everybody's attention again to go through this again about what the long-term treatment goals in asthma management. You know how to treat asthma. The management, the treatment details have been mentioned many times earlier, and you have to keep in mind this long-term goals while you are treating asthma and try to apply this knowledge that we have, all these guidelines that we have to achieve these goals. And how do you do that? Number one up there is patient-doctor relationship or partnership, because now we want the patient to assume some responsibility to make them understand better asthma, all the problems with asthma, and try to convince them that it's necessary for them to do something about it. So avoidance of risk factors has been mentioned earlier. I won't go into details. And the treatment, the assessment, monitoring is important. And that's what the doctors are here to do. And treating exacerbation. If all else fails and the patient gets an exacerbation, we have to deal with it. And again, I want to bring your attention back to this doctor-patient relationship again. And this partnership is very important. We need to educate patients. We need to help them some target for individualized management strategy. It's for that patient. The patient A may have this way of treating asthma, which maybe is a little bit different from patient B. And during this development of this guided self-management, we have to address their concerns. We have to know why they may not want to use the medicine that you give to them. Why certain beliefs that they have may alter the success of your treatment plan. And you need to address that. Otherwise, again, your treatment is not going to be very successful. And you can do what you want, you will come back not using your medicine. So, avoidance of risk factors has been mentioned. Again, we need to individualize this advice, as different people may have different sensitivity to different triggers. And what do you do during your asthma assessment? Just to remind everyone, we have to check on patient medication. It was mentioned earlier, we have to check that technique, we have to make sure they know what they are doing. Very often this is forgotten, as well as, especially when you have a very busy practice, you may not have time to go through this with them, but it's very important. In fact, this may make or break the success of your asthma management plan for your patient. And we have to try to find out why it's a problem and check on the asthma control. How do you determine asthma control? There are many ways. A questionnaire is one of them. You have to examine them, although most of the time when they're stable, examination is pretty normal in these patients. Peak flow monitoring was mentioned earlier. Spirometry monitoring was mentioned earlier as well. I just want to bring you through a case to just sort of illustrate what I've just said earlier. So if I may say that Mrs. James, a 36-year-old housewife, non-smoking, slightly obese lady, she has asthma since childhood, has some allergy to house dust mite and animal dampness. She also has mild allergic rhinal conjunctivitis, pretty common in patients with asthma. And that was being treated with nasal steroids and occasional antihistamine, and she has no other comorbidities. So it's quite a common kind of scenario that we see. In the last few weeks, she reported to you that in the last few weeks she has been using inhaled salbutamol about once daily for her intermittent asthma symptoms. And once or twice a week she used to wake up at night with chest tightness and cough early in the morning. And there's some limitation in the daily activities. She finds that she can't do what she wants because of respiratory symptoms, and she cannot exercise. She used to take fluticasone. In my country, it used to be called Flixotide. And recently, another doctor has given her this salmeterol or fluticasone called Sheraton in my country. I think it's called Bexitrol in this country. However, she didn't really want to take because she was worried about taking too much medication. She's worried about the side effects of the medicine, and she's worried about being over-dependent on medicine. I'm sure you've heard this story before. It's very common again everywhere in practice. So, first of all, before even we go on, how do you classify Mrs. James' level of asthma control? And this is one of the ways that asthma severity is classified, and the NAEPP expert panel review 3 uses this. Do we still use this? We have to be careful when you use this. I think the main caveat is that, and it's also published in the EPR 3 document, that this is only useful right in the beginning if the patient has not had any treatment before. And when you look at this is how you may classify. There's some weakness using this is because after treatment, all this gets sort of changed. You may not be able to use this in the long run. So it may be very useful in the beginning when you see this. It gives you an idea where you are and where the patient is, and helps you guide initial treatment. But after 3 months or 6 months of treatment, this one has now become a little bit more difficult to use, and you may need to think of it or think of control in another way.